Good evening, delegates and participants. Thank you for joining Shield Connect. So today, Obstetric and Gynecological Society of Krishnagiri and Dharmapuri cordially invites you for a live webinar. And the topic is for Journal Club on Bacterial Vaginosis. And let me introduce our moderators for the day. Dr. Anita Thamarai Selvi, ma'am is Associate Professor of OG Government Dharmapuri Medical College Hospital from Dharmapuri, and Dr. Rekha Rajesh, ma'am is MBBS DGO, FICOG DRM from Germany, MRM London, and ma'am is Fertility and High Risk Pregnancy Specialist. So I will hand over the session to Dr. Anita Thamarai Selvi. Ma'am, I welcome you on our platform and I hand over the session to you, ma'am. Thank you, ma'am.
Thank you. Thank you, Nisha. I welcome Chitra ma'am, who's always been there in terms of in times of emergency to support us. Instead of Rekha ma'am, she's moderating the session. Welcome, ma'am. Yeah, Chitra ma'am.
My pleasure. It's my pleasure.
So this is our third journal club. We had in January about star pregnancy, and in February we had a journal club on induction of labor, and this time we have on bacterial vaginosis. We have selected this topic because it is a cause for many of the problems during pregnancy as well as in gynec infertility. So we always during the PG period and UG period, we have so many doubts about bacterial vaginosis. We study it under vaginitis, but we call it as vaginosis. So many doubts. We have to clear the doubts. We have three people representing our Yuva group. First, I invite Soumya to give introduction and overview about what is bacterial vaginosis. Soumya is a second year PG in our medical college, and she's an active and young enthusiastic PG. Soumya, can you start?
Yes, ma'am.
Yes.
1 minute, ma'am. Let me share. Good afternoon, ma'am. Good afternoon, everyone. Myself, Dr. Soumya, second year OGPG from Dharmapuri Medical College, hereby to give an introduction about bacterial vaginosis. First of all, I thank all of you for giving me this opportunity to present in this.
Ma'am, sorry to interrupt, ma'am. Your slides are not seen, ma'am. Can you please stop share and share once again, ma'am? Yeah, can you please share once again, ma'am?
Okay, ma'am. 1 minute.
Yes, ma'am. We can see the screen. Can you please go to the slideshow mode?
Is it okay now?
We can't see the slideshow mode, ma'am. Ma'am, we can't see the slideshow mode, ma'am. Can you please stop share and share again? Don't click any icon, ma'am.
Okay, just stop share and
stop share. Please click the green color share screen and blue color share. Please don't click on the PPT, ma'am. In the dialog box, please don't click any.
Okay, yeah, I get it. Yeah, okay, fine. Is it okay now?
Perfect, ma'am.
Yes,
thank you.
Thank you.
You can start presenting, Soumya.
Yes. Bacterial vaginosis is the commonest cause of abnormal discharge in women of childbearing age. It's also known as Gardnerella vaginosis, associated with alteration in the normal vaginal flora and decrease in the number of lactobacilli in the vaginal discharge. Like lactobacilli or Dodderline bacilli is a normal vaginal flora. There's an 100-fold increase in the growth of other anaerobic bacteria in bacterial vaginosis. Etiology, 50% of the women or asymptomatic carriers, majority complain of vaginal discharge without itching. There is a debate about whether bacterial vaginosis is merely an imbalance in the vaginal ecology or it is initiated as an STA, sexually transmitted infection. Risk factors include vaginal douching, receptive cunnilingus, black race, recent change in the sex partner, smoking, and presence of an STA, that's sexually transmitted infection like chlamydia or herpes. However, it has also been described in virgins, so it is not entirely sure whether STI can be a risk factor or not. Pathogenesis, lactobacilli are the dominant bacteria in the healthy vagina. The pH is maintained below 4.5 in the vagina, and there are low levels of other bacteria. In bacterial vaginosis, the pH of the vaginal fluid is elevated above 4.5, that is up to 6. So the reduction in lactobacillus will allow the other bacteria, that is aerobic and anaerobic, to grow. Lactobacilli may be present, but the flora is dominated by many other anaerobic and aerobic, facultative anaerobic bacteria with concentrations up to 1,000-fold greater than normal. This picture describes the normal vaginal flora, where you can see many multiple dodeline bacilli or lactobacilli. In bacterial vaginosis, you can just see the clue cells, which is epithelial cells studded with other bacteria. Microbiology, Gardnerella vaginalis, Prevotella species, Mycoplasma hominis, Mobilincus, or those that are commonly found. Other species like Etopobium, Clostridiales, or Leptotrichia, Sneathia species may also be there. Bacterial biofilm is a structured community of bacteria in a self-produced extracellular matrix that is adherent to an inert surface or biological tissue. A biofilm consisting mainly of Gardnerella and Etopobium has been described more recently, implicating these two species as critical in the etiology. Associations, increased risk of HIV acquisition in a prospective study of pregnant women with bacterial vaginosis. A study has shown as a decrease in acquisition of chlamydia in women treated for asymptomatic bacterial vaginosis, but this study has limitations, so not sure completely. The prevalence of bacterial vaginosis is high in women with pelvic inflammatory disease. Bacterial vaginosis is common in some populations of women undergoing elective termination of pregnancy, and it is associated with post-TOP endometritis and pelvic inflammatory disease. Vaginally inserted devices such as tampons, IUDs, that is intrauterine devices, and vaginal rings can also be colonized by bacteria, and it can be subjected to biofilm formation. So this might hamper the release of active product in the case of drug releasing devices. In pregnancy, bacterial vaginosis is associated with late miscarriage, preterm birth, preterm rupture of membranes, and postpartum endometritis. It has also been associated with an increased incidence of vaginal cuff cellulitis and abscess formation following transvaginal hysterectomy. But perioperatively, we are using antibiotics, so this risk has been reduced. In one study, it was associated with non-gonococcal urethritis in male partners. Amsel's criteria is used for diagnosis. Characteristics of the vaginal discharge: white, milky, non-viscous discharge adherent to the vaginal wall, pH more than 4.5. So there will be a fishy odor when you mix it with 10% potassium hydroxide. That is due to aminometabolites from various organisms. This is also known as amine or whiff test. Presence of clue cells, that is, as you can see in the image, epithelial cells have a fuzzy border due to adherence of bacteria. There is a gram stain you can do, which has two criteria. Hay-Eson criteria, the modified Eson-Hay scoring system, suggests 5 grades of flora. Grade 0 is epithelial cells with no bacteria. Grade 1 is normal vaginal flora, lactobacillus morphotypes alone. And grade 2, reduced number of lactobacillus morphotypes with a mixed bacterial flora. And grade 3 is mixed bacterial flora only, few or absent lactobacillus morphotypes. And grade 4 is gram-positive cocci only. The Nugent score, also from the gram stain, it's derived from estimating the relative proportions of bacterial morphotypes to give a score between 0 and 10. You can see a normal vagina, there is Nugent score 0. That is, lactobacilli are more common and few to no other organisms. Abnormal polymicrobial preparations or clue cells present, or gram variable coccobacilli, or fewer absent lactobacilli. So it's a Nugent scoring. We can actually calculate the number of bacterium per oil emulsion field in case of lactobacillus, Gardnerella vaginalis, and gram variable Mobilincus species, and we can give a scoring accordingly. And then we have to add these scores, and then if the score is between 0 to 3, it is normal. If it is between 4 to 6, it is intermediate type of bacterial vaginosis, and if it is 7 to 10, it is diagnosed as bacterial vaginosis. Clinical features: symptoms or offensive, fishy smelling vaginal discharge. It is not associated with soreness, itching, or irritation. So many women, approximately like 50%, are asymptomatic. Signs: when you do a perispeculum examination, we can find a thin, white, homogeneous discharge coating the walls of the vagina and vestibulum. Bacterial vaginosis is not associated with signs of inflammation usually. So the treatment will be primary regimen for the treatment of bacterial vaginosis is oral metronidazole 400 mg given thrice daily for 7 days. And we can also use vaginal preparations containing 0.75% metronidazole gel or 2% clindamycin cream, or ovules containing 100 mg OD clindamycin or effective and have few systemic effects. Treatment failure occurs fairly commonly because normal lactobacillus dominated flora fails to become established. We are using antimicrobials, so we are destroying anaerobes and other flora also. So it will take some time for the dominant flora to establish again. So also the persistence of Gardnerella vaginalis and biofilms on the vaginal wall may also be associated with treatment failure. So the treatment of bacterial vaginosis, initial regimen is bacterial vaginosis. We can give metronidazole 400 mg orally thrice daily for 7 days, or we can use a 0.75% gel, one full applicator of metronidazole intravaginally daily for 5 days, or we can use 2% cream of clindamycin intravaginally at bedtime for 7 days. Alternative regimens include tinidazole 2 gram orally OD for 2 days, or tinidazole 1 gram OD daily for 5 days, or clindamycin 300 mg orally BD for 7 days, or clindamycin 100 mg intravaginally at bedtime for 3 days. In pregnancy, we can use metronidazole 400 mg TDS for 7 days. And the first, if it recurs for the first time, we can try the same regimen again, or we can try an alternate initial regimen. If it is multiple recurrence, then we can use metronidazole 0.75% gel intravaginally twice weekly for 4 to 6 months. And routine treatment of sex partners is not recommended. Like as I already told, there's a biofilm formation, and it may lead to recurrent or failure of treatment of bacterial vaginosis. So it is recommended to screen for the increased vaginal pH during pregnancy, as it is useful in reducing preterm birth rates, and vaginally administered probiotics positively affects vaginal microflora composition by promoting the proliferation of beneficial microorganisms. It alters the intravaginal microbiota composition and prevents vaginal infection. Probiotics also reduce the symptoms of vaginal infections like vaginal discharge, and so it is helpful in treatment and as also the prevention of bacterial vaginosis. We can also give probiotic prophylaxis with vaginal capsules containing L. rhamnosus, L. acidophilus, and Streptococcus thermophilus. It resulted in lower recurrence rate of bacterial vaginosis in women with history of recurrent bacterial vaginosis. Thank you, ma'am.
Thank you, Soumya. In short, it is important we have to maintain the normal vaginal flora. If it is not maintained, we will have invasion by other bacteria. So what will be the effect of invasion by other bacteria, anaerobic and aerobic bacteria in pregnancy? We have here Janani to explain about it. Janani?
Good evening, everyone. Today I'm going to discuss about the bacterial vaginosis in pregnancy. Stop share. Share it. Share it. Good evening, everyone. The topic is bacterial vaginosis in pregnancy. Bacterial vaginosis in pregnancy. The prevalence of bacterial vaginosis among the pregnant women.
Screen la perisa varum. Sharing. You select on the green button and blue button.
Stop share.
Stop sharing.
Share screen.
Okay, ma'am?
Illa. Again do it.
Ma'am, don't click on any item, ma'am.
Slide should you do?
Green cell, after that just share, ma'am.
Stop sharing then.
Do a share screen.
Share screen, there is one green button, ma'am. Green arrow. Don't click at any icon, ma'am. Just share that blue icon.
Is it okay?
No, ma'am. And please stop share. Then there is share screen option. Click on that. Then that share button. Don't click at any PPT. And all.
Twice.
Is it okay?
It's still not coming.
Share screen. Click on share. Is it okay, sir?
No, ma'am. After share screen, ma'am, don't click at any icon, ma'am. There is blue, like written is there, na share. You have to click on that only.
Ma share மட்டும் click பண்ணுங்கன்னு சொல்றாங்கம்மா. வேற எதுவும் click பண்ணாதீங்க.
இப்போ ஓகேவா மேம்?
இல்லம்மா, குட்டியா தெரியுது.
இப்போ மேம்?
Okay.
Bacterial vaginosis in pregnancy. The prevalence of bacterial vaginosis among pregnant women varies from 6 to 32%. And in Asia, the prevalence is around 13.6%. 14 to 21% in Western countries. According to CDC, about 1 million pregnancies per year over the globe are affected with bacterial vaginosis. Effect of bacterial vaginosis on pregnancy. It will lead to spontaneous abortion, premature rupture of membranes, preterm deliveries, intrauterine growth retardation, chorioamnionitis, preterm related newborn complications, and postpartum endometritis. Pathogenesis of bacterial vaginosis in pregnancy. In pregnancy, the pathogenic bacteria from the vagina ascend and cause localized interaction in the endometrium. In the endometrium, it will cause incompatibility for the embryo implantation and placental development, which will lead to spontaneous abortion. Bacterial vaginosis and preterm labor. When this, the pathogenic bacteria from the vagina ascend and reach the uterus and release proteolytic enzymes like phospholipase A2 or collagenase, and it will lead to the formation of arachidonic acid, which will in turn lead to the formation of prostaglandins. On the other hand, the pathogenic bacteria itself produces endotoxins like lipopolysaccharides and binds to toll-like receptors in the cells, and which will in turn release the tumor necrosis factor alpha, interleukin 1 beta, and interleukin 6, which will also in turn upregulate the production of prostaglandins, which will lead to preterm labor. Importance of screening. Screening, our main focus today is on the importance of screening of bacterial vaginosis in pregnancy. Mostly the pregnant women are asymptomatic, whereas the characteristic symptom is only the vaginal discharge, which will not be causing that much harm to the women, so that they will not come out with the symptom. So the women is always often asymptomatic. Whether asymptomatic pregnant women deserve or would benefit from the therapy is also less defined. So more than half of the women with bacterial vaginosis have no symptoms in the lower genital tract, but they are still affected in terms of the complications like preterm deliveries, spontaneous abortions and all. So factors favoring screening. Why should we screen pregnant women for bacterial vaginosis is that the condition is more common. It has a prevalence of about 30%, and it has reasonably reliable tests are available to perform screening. And the potential consequence of not treating bacterial vaginosis are severe for the mother and the fetus. And effective therapy is also available. So these are the factors which will favor screening. Screening in pregnant women. Bacterial vaginosis is often screened in the mid-pregnancy in the second trimester, which the mothers infected in this trimester are in the greater risk for developing complications. Based on the increased risk, current CDC guidelines recommend screening early in the second trimester. The screening tool used is Amson's criteria, which is readily available and is cost effective. Whom should be screened? The screening is not routinely done for all pregnant women. Currently, only pregnant women with the history of preterm delivery are known to be high risk for high risk group, and they are screened routinely for bacterial vaginosis. Screening and treatment is effective or not. Based on the study on bacterial vaginosis in pregnant women and associated factors on maternal and fetal outcome in Chitti Siddha et al. And International Journal of Reproduction and Contraception, Obstetrics and Gynecology, 2019. Both asymptomatic cases, when compared to symptomatic cases, routine cases leading to need for routine screening. Routine screening of antenatal women resulted in the decrease in the adverse pregnancy outcomes. Screening and treating pregnant women with bacterial vaginosis will prevent preterm birth and its complications. When the screening is widened for women with abnormal flora, there is a 47% reduction in the preterm births, according to Brocklitz et al. Study. Preterm delivery was reduced in pregnant women who had a previous preterm birth and an imbalance in the bacteria in bacterial flora in the vagina during the current pregnancy. Morales et al. Study. Women with bacterial vaginosis during pregnancy should be aggressively evaluated and effectively treated. This is particularly true for women considered at high risk for pregnancy-related complications. Asymptomatic pregnant women with bacterial vaginosis may also benefit from therapy. Treatment of bacterial vaginosis. According to ACOG guidelines, metronidazole 400 mg orally twice daily for 7 days, or tablet clindamycin 300 mg twice daily for 7 days. Clindamycin is usually used in first trimester of pregnancy. Metronidazole gel 0.7%, 5 grams, which can be intravaginally applied once daily for 5 days, or 2% clindamycin cream can be applied intravaginally once daily for 7 days. According to CDC, the bacterial vaginosis in pregnancy can be treated with 250 milligram tablet metronidazole 3 times a day for 7 days. Oral antibiotic regimen is more efficacious than the topical antibiotic regimen. Hauth and colleagues showed that pregnant women who had bacterial vaginosis and increased risk for preterm delivery received metronidazole and erythromycin therapy, a significantly reduced rate of preterm delivery when compared with the women with the placebo group. And there is the percentage of incidence was about reduced about 39% versus the 57% in the placebo group. Morales and colleagues also demonstrated that oral metronidazole therapy reduced the rate of preterm births for pregnant women with bacterial vaginosis and a previous history of preterm birth when compared to women who received placebo, which was also there is a reduction in the incidence, which is about 18% versus 39%. Probiotics in bacterial vaginosis. According to J. Clin Gynecology Obstetrics 2019, oral administration of lactobacilli was found to be more effective in treating bacterial vaginosis than vaginal route. Orally, about 10.9 to 10.10 colony forming units is a standard dose believed to be required for the passage through the intestine to the reach vagina to displace the pathogens. Lactobacilli of choice used is Lactobacillus rhamnosus and Lactobacillus reuteri. The mechanism of action of probiotics is that the probiotics metabolize the glycogen from the vaginal epithelial cells and causes lactic acid production, which will produce a vaginal pH which will be less than 4.5, which is acidic, which is unfavorable for the other pathogenic organisms. Whereas on the other hand, the probiotics Lactobacillus species itself will produce bacteriocin, H2 hydrogen peroxide, collagen binding proteins, which will increase the interleukin 10 and colony stimulating factor 3, which will downregulate the lipopolysaccharides produced by the pathogenic bacteria, and tumor necrosis factor alpha. The take-home message is that women affected by bacterial vaginosis are often asymptomatic. Screening is not routinely recommended for a pregnant women. Only women with high-risk group for preterm deliveries can be screened, and oral antibiotic therapy can be given, which is efficacious, and probiotics or antibiotics are also used prophylactically for bacterial vaginosis treatment. Thank you.
Thank you, Janani. It was a very crisp rendering. And in a nutshell, I think you can just say that all pregnant women who are suffering from bacterial vaginosis is basically they will be asymptomatic.
Yes,
and the treatment is very simple and safe and an assured positive outcome in pregnancy.
Yes,
and so we have to be more, in order to be not taken unawares by bacterial vaginosis complicating pregnancy, we have to look forward. Unless you see for it, we will miss it. Isn't it? So just like how we say think ectopic in all normal first trimester pain and bleeding cases, we have to also think of bacterial vaginosis in pregnancy. It's becoming more and more common because, as you said, nearly 30% are afflicted. So we have to be aware and we have to be on the guard in treating pregnancy with bacterial vaginosis. Thank you, ma'am.
Thank you, ma'am.
Thank you, Janani and Soumya. preterm labor is a major problem, preterm delivery, and it is an important cause for perinatal mortality. Probably, if we think more about bacterial vaginosis, probably we'll be able to reduce the preterm baby deliveries. Now we have Sushma, she's the leader for our UA Foxy team, UA team, and she is here to tell about bacterial vaginosis effect over infertility.
Thank you, ma'am. Mrs. Chitra Shikala, can you please share the screen?
Yes, ma'am, I'm sharing. Are the slides are visible?
Thank you so much. Good afternoon, one and all present here. I thank OJSOK, I thank Chitra ma'am, Anita ma'am, Rekha ma'am for giving me this opportunity to speak about the bacterial vaginosis and its association with infertility, endometritis, and pelvic inflammatory disease. Generally, to begin with, bacterial vaginosis is a very common lower genital. Please change the slide. Bacterial vaginosis is a very common lower genital tract infection with a prevalence of about 29%. It usually works and it's associated with disruption of optimal vaginal microbiota. Bacterial vaginosis is associated with the following microorganism, mainly being Gardnerella vaginalis. Please change the screen. Usually, the ladies or women are asymptomatic and they may present with only one complaint of vaginal discharge with odor, without any itching. So there are serious adverse health outcomes related with bacterial vaginosis. It increases the risk of infertility. It causes adverse pregnancy outcomes as previously told by Dr. Janani, and it increases the susceptibility of the cervix and vagina to other sexually transmitted infections like chlamydia, gonorrhea, HPV, and HIV. And it causes upper reproductive tract infection like that is pelvic inflammatory disease and also endometritis. I am going to discuss in detail everything. So first, the diagnosis and treatment of bacterial vaginosis. Clinically, there is increased levels of vaginal discharge associated with a strong fishy odor, and diagnosis can be done by Amsel's criteria. Nowadays, the commercial molecular tests are available wherein we can do genetic sequencing or PCR for the organisms that are associated with bacterial vaginosis. Otherwise, in research centers, there is a Nugent scoring system where in high Nugent scores reflect absence of lactobacillus and presence of strict anaerobes, that is Gardnerella and Moblincus species, and low Nugent scores represent high abundance of lactobacillus. So usually the treatment for bacterial vaginosis is metronidazole. We can, next slide, please. Next slide, please. I think you have gone too much. The previous slide. Yes.
This one, ma'am?
Correct. The recommended treatment regimens according to ACOG include metronidazole 500 mg twice daily for 7 days, metronidazole intravaginal gel 0.75% once daily for 5 days, and clindamycin intravaginal cream 2%, that is 5 grams once daily at bedtime for 7 days. Alternative regimens, which is the advancement in the bacterial vaginosis treatment, wherein the dosing and the number of days is decreased, is secnidazole. We can give oral tablet 2 gram single dose, and tinidazole oral tablet 2 grams once daily for 2 days. And again, you can give tinidazole 1 gram for 5 days, and clindamycin oral 300 milligram twice daily for 7 days. So it is proven that single dose of 2 grams secnidazole is as efficacious as the normal regimen of metronidazole in women. So this is the recent advancement in the treatment of bacterial vaginosis. So even though next slide please, even though we treat with antibiotics and the treatment efficacy is high at 3 to 4 weeks after treatment also, bacterial vaginosis is highly recurrent. That is 58% of women with bacterial vaginosis recur within 1 year. So the reasons for recurrent include non-adherence of treatment or persistence of residual infection. That is, after 1 week, if we check and the dose is not enough and there is persistence of residual infection and formation of biofilms by the bacteria that is associated with bacterial vaginosis, which prevents the action of antimicrobials over the organisms and the development of the organisms which are resistant to antimicrobials. Again, if there is any reinfection, repeated reinfection from partners of either sex, there is increased chance of recurrence. Next slide, please. Asymptomatic bacterial vaginosis include Negen score between 4 to 10. But there are, if the women is not having any symptoms, the CDC recommends that these women should not be treated unless they are not for any treatment. That is, when they are asymptomatic, treatment is not recommended, as even if treatment is given, the outcome is not matching to those who have been not treated. So the CDC recommends, although the recurrence and associated costs are high in asymptomatic women, treatment for these women is not recommended. Diagnosis and treatment of bacterial vaginosis. This advances in bacterial vaginosis treatment, antibiotics that require less frequent dosing, as I already informed about secnidazole, because it requires less frequent dosing and it is a single dose, which is, and it is as efficacious as the treatment of metronidazole, wherein they have to take the tablets thrice daily for 7 days. And in a recent double-blinded placebo-controlled trial, the use of Lactobacillus crispatus after treatment with vaginal metronidazole resulted in significantly lower incidence of bacterial vaginosis recurrence versus placebo even after 12 weeks of treatment. So combination of antimicrobials and Lactobacillus crispatus, which restores the normal vaginal flora and the vaginal pH, is beneficious to prevent the recurrence. Coming to the association between bacterial vaginosis and fertility, bacterial vaginosis is linked to increased risk of infertility, particularly tubal fertility. In a study of women undergoing oocyte recovery for in vitro fertilization, seropositivity for chlamydia species and presence of bacterial vaginosis were both strongly and independently associated with tubal fertility. In women with idiopathic fertility, there is, when we tested the vaginal discharge, there was a unique vaginal bacterial signature that includes the bacteria related to bacterial vaginosis. So in women with idiopathic infertility, nearly 50% of the women had bacterial vaginosis, related vaginitis, endometriosis, and pelvic inflammatory disease, which leads to infertility. So, and in a systematic review of studies assessing bacterial vaginosis and infertility, bacterial vaginosis was 3.3 times more likely to be identified in infertile women than antenatal women of the same population. Women with lower recurrence of vaginal lactobacilli were less likely to have the successful embryo implantation. As said correctly by the previous speaker, there is a change in the endometrial thing wherein there is a lot of inflammation and immune cell accumulation, which leads to the disruption in the endometrial environment, and it will cause alterations in the attachment molecules, which leads to failure in embryo implantation. Although there is a clear association between bacterial vaginosis and infertility, the causality has not been conclusively determined, and further research is required in this area. So the cause for infertility when the woman is affected with bacterial vaginosis, as I already said, it induces immune activation through dendritic cell maturation, and there are increased levels of pro-inflammatory cytokines, resulting in mucosal inflammation of the genital tract. This mucosal inflammatory cells will keep the seminal fluid components as immune targets and destroys the cells that is present in the sperm, which supports the sperm and also the sperm, leading to infertility. There is high level of cervical interleukin cytokines, which have been reported in women with infertility who are having bacterial vaginosis. Restoration of normal vaginal microbiota with use of probiotic vaginal tablet containing lactobacilli has been shown to reduce the levels of pro-inflammatory cytokines and in turn improve the fertility rates of these patients. Next slide, please. The other cause, one is the immune activation that it does in the vagina. The other cause for infertility when women having bacterial vaginosis is the disruption of cervical mucus integrity. Cervical mucus is the defense mechanism of upper reproductive tract from microbial invasion. When these microorganisms produce hydrolyzing enzymes, which includes mucinases that degrades the cervical mucus and ascend to the upper reproductive tract. These enzymes also work to enhance the bacterial adhesions and subsequent colonization in the upper reproductive tract, which leads to infection and in turn infertility. So the other reason is the bacterial vaginosis has shown to increase the susceptibility of chlamydia trachomatis and gonorrhea by 3.4 and 4.1 fold respectively. And the other common infection that the bacterial vaginosis is associated is Trichomonas vaginalis, herpes simplex, HPV, and HIV. So vaginal colonization with lactobacilli has been shown to be protective from chlamydial or gonorrheal infections. So bacterial vaginosis has also been associated with subclinical PID, that is where there is asymptomatic ascension of infectious agent to the upper respiratory tract, which is 2.7-fold more common in patients with bacterial vaginosis, this asymptomatic PID or subclinical PID. So the presence of bacterial vaginosis associated bacteria in endometrium has also been associated with recurrent pelvic inflammatory disease and persistent endometritis, even after the recommended treatment with cefoxitin and doxycycline, which we give for acute PID. So finally, to tell the causes of infertility in women with bacterial vaginosis, there is immune activation, which destroys the cells in the seminal fluid, which leads to infertility. There is inflammation. There is toxin production, which with hydrolonic enzymes and mucinases, which disrupts the cervical mucus, and there is ascension of infection. And the bacterial vaginosis makes the lower as well as the upper reproductive tract susceptible to sexually transmitted infections, and it makes the endometrium susceptible for pelvic inflammatory disease, all of which finally leads to infertility. And it has a very keen association with endometritis and pelvic inflammatory disease also. Initially, acute PID, the clinical symptoms with acute PID or women with acute PID present with cervical motion tenderness, uterine tenderness, adnexal tenderness, whereas fornicial tenderness, as we usually tell on perivaginal examination. When we do a biopsy, endometrial biopsy, there is histopathological evidence of endometritis, wherein there will be a lot of inflammatory cells present in the tissue, and the laparoscopic findings that are consistent with the acute PID. If at all we do a laparoscopy, there will be adhesions, flimsy adhesions and discharges in the parametrial area. Subclinical or chronic PID, this is a new entity where there is persistent of infection for longer period, and there are very non-specific symptoms wherein the patient presents only with pelvic discomfort, spotting, and leukorrhea repeatedly with us, and we also treat, but there is a recurrence. And the presence of endometrial stromal plasmocytes is specific and a sensitive finding for chronic endometritis when we do endometrial biopsy. This is a histopathological finding. It is a more specific finding. So when such things are there, usually if there is a bacterial vaginosis associated bacteria in endometrium, there is a 3.4-fold increased risk of infertility. And women with subclinical PID has a diagnosis of 40% decreased likelihood of pregnancy compared with those without subclinical PID. And the tubal infertility was found in 10.8% of patients diagnosed with PID compared to 0% of those who tested negative. So infertility was reported in 24.2% of women with past PID treatment compared to 13.3% of women without PID treatment. So chronic endometritis has also shown is highly prevalent among women with unexplained infertility. This chronic endometritis usually is caused by bacteria associated with bacterial vaginosis. Though in those with endometrial microbiota dominated by non-lactobacilli were significantly less likely to have successful implantation, pregnancy, or ongoing pregnancy. Chronic endometritis cure with antimicrobial treatment has shown to improve the outcomes in women undergoing in vitro fertilization, IVF treatment. So the cause for infertility in endometritis and PID is there is disrupted inflammatory and immunologic signatures, wherein there is uterine immune cell infiltration inside the endometrium, which causes abnormal levels of chemokines and alteration in adhesion molecules, leading to decreased trophoblastic implantation. And these immunologic and inflammatory changes disrupt the endometrial function and decrease the receptiveness of the endometrium to endometrial implantation and development. The other factor, as I already told, is the tubal infertility. There is pathological tubal inflammation, which leads to fibrosis and subsequent scarring, leading to infertility. Recurrent chlamydia trachomatis infections lead to mononuclear infiltration, fibroblast proliferation, and connective tissue deposition, culminating in fibrosis of fallopian tubes, which in turn leads to infertility in the patient. So, management includes treatment of women with chronic endometritis resulted in a significantly higher pregnancy rate, that is 6.8 times than those with persistent disease. So treatment is recommended for those with unexplained infertility, and when we test whether if they are positive for bacterial vaginosis, the treatment of such patients improves the fertility rate. So colonization of catheter transfer tip with beneficial lactobacilli at the time of embryo transfer may improve the implantation rates. This is a new point that I noted. Colonization of catheter transfer tip during embryo transfer with beneficial lactobacilli also may improve the implantation rates in such women. And treatment of PID with metronidazole and ceftriaxone and doxycycline was shown to eradicate the anaerobic bacteria from the endometrium and decrease the pelvic tenderness at 30 days. Screening for chronic endometritis should be considered in women with unexplained infertility, repeated implantation failures, and recurrent miscarriages. So finally, I would like to conclude that the sequelae of bacterial vaginosis is bad when we take in terms of endometritis, or whether it is vaginitis. It finally leads to infertility. Symptomatic and sometimes asymptomatic bacterial vaginosis should be urgently treated to prevent this sequelae, maybe STI, PID, and endometritis, which all seem to contribute to infertility. Thank you.
Thank you, Sushma. It was a clear presentation about the importance of bacterial vaginosis in causing infertility. Thank you, Sushma. Okay. So we'll come to the end of the session. We are already used to gut flora, the good gut flora, but we are not very much convinced about healthy vagina. Vagina, even though we call it as external genitalia only, it's an important reproductive organ that is important in terms of beginning of reproductive life and also for successful ending of reproductive life. So this has to be healthy. And the flora has to be maintained. So we have to think in terms of bacterial vaginosis in cases of repeated preterm delivery and infertility, which is very, very common. Both preterm babies and infertility is increasing. And the most important cause now identified is the normal flora of the vagina is not maintained and it is being invaded by organisms which causes bacterial vaginosis. So we thank you for selecting this topic, Sushma. So this is very important. We have to understand our healthy vagina is very important for a healthy reproductive life, both for conceiving as well as for having a successful vaginal delivery. And I would also like to thank Shield Healthcare, Nishant and others for sponsoring our webinar all weeks. And thank you, Chitra ma'am. Chitra ma'am, are you there?
Yeah, I'm very much here. I was just admiring the way you were getting it through. Good. Go ahead.
That's all, ma'am.
Yeah, I mean, I think it was a very crisp and very completely, they have covered all the topics in regarding bacterial vaginosis, and it cannot, much more stress cannot be made than what they have already done on the importance of bacterial vaginosis in with regards to infertility, preterm delivery, and of course their proneness for further cancer, cervix, lung, all up to the STDs, on HIV, on immunosuppressive diseases, etc. So bacterial vaginosis is very simple to treat, very easy to identify, and it is a very short-term treatment without any side effects. And the take-home message among all that, I think, as Sushma said, the catheter tip for those who are doing IVF procedures, the catheter tip should be coated with lactobacillus, she said. That's a very important and new. I have never heard of that before. So coating the catheter tip during embryo transfer with lactobacillus molecules, maybe it is going to help in the outcome. Isn't it? That is what she meant. Am I right?
Yes, ma'am. Yes, ma'am.
That's a very new
one, but it is not made as a guideline, ma'am. But some studies have proven that it is the outcome
is a very new way of looking at it. That is, it's going to help us.
So not only the vaginal flora, the endometrial flora is also
flora is, so that implantation will be able. Yeah.
Thank you.
Thank you so much for everything, and thank you, Shield, for being with us every month, and I hope you continue to be with us in subsequent months also.
Thank you for everyone who participated in the meeting. Yeah. We had 32 participants. Thank you.
Next month, we'll choose the next.
Thank you so much, ma'am.
Thank you all.
Thank you.
Both of you are very good. Bye.
Thank you, ma'am. Thank you.
Thank you, ma'am.
Bye, sir.